diet, appropriate diet. We always say that good fiber diet, good water, avoiding fizzy drinks, they're all very good. Avoid smoking. Sedentary life and obesity are really bad. And where there is screening program, it's encouraged that everybody should comply, because if you comply with the screening program, your chances of being picked up early with cancer, it's quite commensurate with the type of treatment and the prognosis that you get. Now, there are non-modifiable factors which nobody can do anything about, but once those ones are identified, patients can be followed up strictly in the hospital. So if there is a family history of colorectal cancer, there's a program whereby they can be followed up regularly. Patients with inflammatory bowel disease, for instance, ulcerative colitis, there is a 3% risk of developing colorectal cancer in 10 years. So they have to have regular colonoscopy and a regular checkup. Patients with previous cancer also are at risk of developing cancer. So those ones are non-modifiable, but it means that they have to be followed up regularly and appropriately. So the next slide show the statistics in UK, which only suggests that it's almost like a summary of what I've said just now. 42,000 cases from the Cancer Research UK, and out of the 42,000 cases, about 16,000 deaths and 57% survival. So, which is really, really sad. So 57% survival. But what is actually promising is that if there is appropriate screening program, about 54% of the cancer death can be prevented. Therefore, the emphasis now is to focus on screening in terms of improving survival in colorectal cancer. So you can see 54% are preventable. So the key point really in colorectal cancer will be to do a proper screening and then pick up patients who have early polyp cancer and offer surgery or excision, and that will offer the best treatment survival. We also know that patients with rectal cancer are more difficult to treat, and the treatment is still evolving. There are a lot of modalities involved presently, which includes radiotherapy, chemotherapy, and in terms of surgery, we also know that robotic surgery is fairly superior to open surgery in rectal cancer. So those are areas that are still being developed. We also know there are synchronous tumors. So when a patient has a tumor in one part of the colon, there is about 5% risk that that patient has a tumor in another part of the colon. So therefore, they have to have full colonoscopy. And lastly, patients with liver or lung metastasis, they are stage 4 cancer. If left untreated, the prognosis in 5 years is 5%. So not many of them will survive 5 years. Will survive after 5 years. There is where the MDT is quite good. With the MDT, the survival and their quality of life have actually been improved dramatically, and about 50% of patients with lung or liver metastasis have been shown now to survive longer than 10 years. So in terms of summary, what I will want us to take home from this discussion or from this presentation today is that, one, we need to focus on screening. Screening will ensure that we detect cancer early, or at least find patients who are at risk. And therefore, we'll be aiming at monitoring them. And when the patient comes to surgery, then we have to make sure that at the first resection, we get an arrow resection. Arrow means that all the resection margins are completely free of the tumor. So when these are done properly, the patient survival risk is lowered significantly. So that brings me to the screening, where what we're actually looking for are asymptomatic patients who may have underlying polyps that can be removed in order to prevent colorectal cancer. I mean, that's basically what we're doing in screening in colorectal cancer. They are asymptomatic, and you're expecting, first of all, that there will be nothing found in them. That if there's something found in them, there will be polyps, and these polyps can now be treated in order to stop it from progressing into something serious later. On the average, it takes about 5 to 7 years for the polyp to change into proper cancer. I'll show you a diagram later on. We show the adenoma cancer polyp sequence. By and large, polyps are quite small. You can see some diagrams some pictures on the slide. They are small. It's difficult to tell when you look at the polyp endoscopically if they are benign or if they're malignant. But there are some things that will give you a clue as to whether polyp is benign or malignant. If they are small, usually less than 1 centimeter, or smooth or solitary, or on the left side, they are more likely to be benign. And if you want to be clever, you can also change the variation on the colonoscopy. You can actually see by using different forms of infrared program to see if the polyp is smooth, and if you can actually have a lot of light refraction from it, which will indicate whether the polyp is smooth or it's rough. Generally, a large polyp will bleed, and that polyp will lead to a positive fecal occult blood test, which is also a basis for screening. On the next slide, it just tells us the 2 types of polyps that are available or that we should be aware of. One, I would say, non-neoplastic polyp, and the second type is neoplastic polyp. So non-neoplastic polyp, by and large, are not polyps that we should worry about. They are not going to turn into cancer, and we do need to remove them, send them for histology, and if a patient comes back to be non-neoplastic, they can be reassured. Whereas if they have a neoplastic polyp, these are adenomas. The adenomas are either sessile or pedunculated, or some of them can be flat or depressed. They also should be sent for histology. The adenomas can be villous or tubular or tubulovillous. Now, these are the ones that are possibly neoplastic and have malignant transformation change. And the next slide will show the relative risk of size of polyp, and the prediction of cancer in the polyp. So if you have T represents tubular and V villous, so it's more likely that you have a malignant polyp with a villous adenoma rather than a tubular. So if you look at a small tubular adenoma that is less than 1 centimeter, the risk of that being a cancer is almost 0. Whereas if there is a polyp which is greater than 2 centimeters, which is villous, the risk of finding cancer in that polyp goes as high as about 60%. So when the information is quite good, because when you send them for histology and the histology comes back to be tubular adenoma less than 1 centimeter, you can tell that that polyp is has zero potential of containing cancer. The other thing that is good among in the histology to look for is the degree of dysplasia. So you have a moderate dysplasia or severe dysplasia. If it's a low-grade dysplasia, that will be as good as normal. You're still not going to discount that. It just means that the patient can be reassured, and the timing or the length of the follow-up colonoscopy can be increased to 5 or 10 years, depending on the age of the patient. Whereas when you have a patient who has a polyp which contains severe dysplasia, that is almost precancerous, that patient almost certainly will need to be treated within 6 months. Otherwise, the risk of cancer within 6 months to 1 year becomes quite high. So this slide really tells the whole story of the basis of screening, the adenoma cancer sequence. As I said earlier on, if it's a non-neoplastic, if it's not an adenoma at colonoscopy, you've done your histopathology and it's not an adenoma, for instance, if it's an inflammatory polyp, then you don't need to worry. But if it's an adenoma and it's quite large, this slide tells the natural history of adenoma from a normal polyp, which is in the hyperproliferative stage, which is still considered to be benign. They can go on to what we call the early adenoma stage. And from the early adenoma, I go on to the intermediate adenoma and then the late adenoma. Now, by the time you get into the late adenoma stage, the degree of differentiation there is quite high, and that patient is more likely to be turning towards severe dysplasia with precancer. Looking at the polyp endoscopically, you really cannot tell the difference between all this. The only thing you can tell is the relative size. On the next slide, if you look at the next slide, that just shows the relative influence of what we call chromosomal instability. Again, I'm not going to go into that in full detail. It's one of the mismatch repair gene that is identified in some patients, which actually predispose them into developing polyp and developing carcinoma. So those are the areas that I will employ to go and read into details. But this definitely forms the basis of screening. And if you imagine that the patient is picked up at an early stage with a polyp, and that polyp is removed, that patient is not likely to progress to develop colorectal cancer. Whereas if a patient does not have that polyp removed, it's predicted that over a period of 2 to 5 years, that polyp will undergo transformation and it will become cancer. Now, on the next slide, it just shows the various classifications of polyp cancer. If there's a cancer in a polyp, you can see that we either use the Haggett classification or what we call the Kikuchi. Now, the Haggett classification is really good for a pedunculated polyp. because what you're measuring is the level of the cancer that is involved in the polyp. So as long as the stalk, the base of the polyp is not involved, and you can snare off the polyp completely, then you can be rest assured that you've treated that patient and you don't need any major radical resection for that patient. For instance, on this slide, if there's a patient with a Haggett level 1, for instance, Haggett level 1, and you've done your polypectomy, it's assumed that the polypectomy will be at the submucosal level. So that will be the only treatment for that patient. You don't need to do any more radical resection. Whereas if a similar patient has a Haggett level 3, that means the stalk is already involved, the submucosa is already involved. It is very, very difficult to achieve a complete excision when you do polypectomy endoscopically. So a patient like this, if they are young, you are likely to go on and do a proper oncological cancer resection. I said if they're young because you have to consider a frail old lady who has a Haggett level 3. Offering them a resection may not be a good thing because the risk of surgery probably outweighs the risk of them developing a problem from the cancer. On the other hand, when you look at the second picture on the right side, it's good to use what we call the Kikuchi classification for that, because that will now look at the depth of invasion. It's still a polyp, it's still in the submucosal level, but what you're looking for is the degree of penetration into the muscle layer. Now in Kikuchi grade 1, it's still all limited to the first layer or to the epithelium basically. Whereas when you're looking at Kikuchi SM3, it's already penetrated the submucous going to the muscularis propria. So all this information are usually what you will expect to obtain from your histopathologist, and that will help you in deciding the type of treatment that you offer the patient in terms of whether you offer them a simple polypectomy or you go on to radical oncological cancer surgery. So I suppose what I've been trying to say about polyp is that if you detect a polyp by doing a proper screening or proper colonoscopy, it saves lives. It will improve the pickup rate of polyps and subsequently stop the transformation into colorectal cancer. So there's a bold statement down there that for every 1% increase in, sorry, the next slide, please. Yeah, for every 1% increase in adenoma detection rate, colorectal cancer incidence is reduced by 3%. And for every 1% increase in adenoma detection rate, colorectal cancer mortality is reduced by 5%. So if we remember anything from this meeting at all, I think it should be that our focus on polyp treatment should be improved. Because if your patient, if we can do a proper colonoscopy, remove the polyp, it's more likely that will improve survival in colorectal cancer. Now, the next slide showed a post-polypectomy patient. As you can see, this patient has a polyp which has been lifted up. You can see the blue line around the polyp that shows the Indian ink that's been used to mark the polyp and also to lift the polyp up so that you can actually have what we call an endoscopic mucosal resection. So endoscopically, you can remove that cancer. Because there's going to be a large, deep gap in the lumen of the colon, which may predispose the patient to bleeding or even perforation, what you do is to apply endoclips. Okay, this is magnified on this picture, but actually the endoclips are just like sutures. You put them to bring the mucosal surface of the resected margin together, and that's all there is. So the clips fall up after several weeks. By the time you repeat your colonoscopy, maybe in 6 months or in 1 year, it's all healed very well. It will be proper at this stage to say that in the United Kingdom here, there is what we call the National Bowel Cancer Screening Program. I'm sure it's also in America, it's in most parts of the world. It's something that is going to come eventually in Nigeria. The bowel cancer screening program was started because of what I've been trying to say all along, that if you pick up polyp at the early stage and you remove them, then you stop the progression of this polyp into colorectal cancer. So the screening program usually starts at the age of 55 in UK. In America, I think they start at 45 or maybe 50. And it stops at 75, not because it's considered that at 75 you're going to be diabetic. In most countries, actually, the average lifespan is about 75. And it's thought that if you stop at 75, then it makes economic sense. A lot of our patients still actually come in after 75 on their own to have screening. So what this entails in the beginning is the patients go to the general practitioner and they have a stool test. The stool test used to be what we call a fecal occult blood test, which is not as sensitive. But now we have what we call Q-FIT test. Q-FIT is quantitative fecal immunochemical test. It's more like check the DNA and sorry, not DNA. Check DNA. Yeah, it's more sensitive in terms of picking up blood in the stool, whereas the FOB is less sensitive. You can see the sensitivity of FOB is about 30-50%, whereas in Q-FIT, the sensitivity is up to 80%. So essentially, when the Q-FIT test is positive, the patient is now called up to have colonoscopy. And colonoscopy is gold standard for investigation of colorectal cancer. In good hands, you pick up polyps as small as 5 millimeters in 95% of cases. Alternatively, if the patient is not suitable for colonoscopy, you can consider CT colonography, but we tend to advocate colonoscopy. The next slide, again, is probably just a summary showing that in general, male are more affected than female. Survival in female is better than in male. I do not know why. But the good thing is that stage 1 and stage 2, you can see the survival rate is almost approaching 100%, definitely greater than 80%. The best cancer is the blood cancers, the leukemia. I think those are the ones where you can achieve about almost 100%. So in all forms of cancer, colorectal cancer of 90% cure rate is actually quite good. Now, this survival rate drops down dramatically at stage 3, and then stage 4, it's hopeless. It's almost like 5%, 5 years survival at stage 4. Unfortunately, most of the patients that are symptomatic are already at stage 3, and that's why we still struggle. So when the patient comes in at stage 3, or when they are symptomatic, they're already more or less in stage 3, which means the survival rate, 5-year survival, is around 60%. So this is where we need to improve on in terms of getting them before they have symptoms, so that we can push it more to the left side rather than to the right side. Now, at stage 4, it's not entirely hopeless. This is where the multidisciplinary team comes in, where you have the liver surgeons and the cardiopulmonary surgeons. A lot of other modalities can be thrown at the patient in order to achieve a better survival. So at stage 4, with treatment at the MDT, you can actually bring this up to about 50%. So the next slide is really for those who are interested. I mentioned this earlier on. This is about the family, patients with family history of colorectal cancer. I'm not going to go through that. I think it's really for the pocket. So you keep that and then have a look. It just shows what Lynch syndrome and FAP and the type of follow-up that are required for them. So that brings me to the colorectal cancer proper. This is where we make the diagnosis and then we talk about the treatment. And at this point, maybe perhaps Dr. Idokun, if she's ready, we can have the case presentation before we go on to the diagnosis and treatment of colorectal cancer. Would that be possible? Dr. Adedeji? Yeah, okay. While you're getting ready, I can briefly talk about the symptoms of colorectal cancer, which is shown on this slide. What we call there's something we call high risk symptoms. So not all symptoms will indicate colorectal cancer, but a high risk symptom would be something like a rectal bleeding or change in bowel habit, which is unexplained, of at least 3 weeks duration in a patient of 40 years age or above. We consider to be high risk. And the other high risk symptom would be iron deficiency anemia, which is probably common in Africa because of sickle cell, but in Europe, anybody with iron deficiency anemia is considered to be at high risk because of possibility of a right-sided colon cancer. Okay, Dr. Idokun.
Okay, Dr. Idokun, do you want to share your screen?
All right, sir. Can you see my screen, sir?
Yes, we can.
Okay. Good afternoon.
Good afternoon.
Sir. I will be taking the case presentation. AG was a 57-year-old married clergyman who presented with abdominal pain and swelling of 2 months duration and constipation of 2 weeks prior presentation. The pain was insidious in onset and dull in nature. It was located in the right iliac fossa. It was non-radiating, no aggravating or relieving factor. The right iliac fossa swelling was noticed at the same time, which progressively increased in size. It was associated with constipation and vomiting. However, there was no change in stool caliber, no hematochezia or tenesmus. There was no preceding history of trauma to the abdomen. There was passage of melena, weakness, and dizziness, but no fainting spell. There was weight loss, anorexia, and easy fatigability. He has no family history of abdominal malignancy, no exposure to radiation. There was no history suggestive of metastasis to any part of the body. He was referred to UCH on account of CT scan he did at the peripheral center. He has no comorbidity, no previous surgery or blood transfusion. He was married with children, was married with 4 children in a monogamous family setting. He didn't smoke cigarettes nor drink alcohol. Examination revealed a middle-aged man who was conscious, afebrile, not pale, anesthetic, well hydrated. There was no peripheral lymph node enlargement, no pedal edema. It was tachycardic with pulse rate of 106 per minute. Other vital signs were within the normal limits. Abdomen was distended. It moved with respiration. Right iliac fossa mass was palpable, was hard, it was non-mobile, and it was tender. The liver was enlarged, about 4 centimeters below the right costal margin. It was soft and not tender. The spleen and kidney were not palpably enlarged. The bowel sound was hyperactive. The ascites was not demonstrable. On digital examination, the signal finding was moderately enlarged prostate with benign features. However, it was essentially normal findings. So we made the diagnosis of sickle pole tumor complicated with small bowel obstruction. The CT scan he brought revealed an ascending colon mass with multiple enhancing lesions on the liver. The X-ray, the plain abdominal X-ray done also showed dilated loop of small bowels with multiple air fluid level. At this point, our plan was we commenced on nape per mouth. Nasogastric tube was inserted for gastric decompression. Urethral catheter was inserted, was commenced on fluid and antibiotics, and was worked up for exploratory laparotomy for relief of obstruction. His full blood counts are essentially normal. He has an elevated serum carcinoembryonic antigen of 80 nanogram per ml. Was hypokalemic of 2.8 millimole per liter, which was corrected to 3.6 millimole per liter. All other investigation results were normal. At surgery, we found about 300 ml of acetic fluid. There were extensive there was extensive peritoneal staining with tumor, and the mass was found on the cecum and ascending colon, which was not mobile. The intestine were dilated, and they could not feel. They are unable to be mobilized, and multiple nodular liver metastases were noted. The patient had ileostomy done. The histology of the biopsy revealed moderately differentiated colonic adenocarcinoma, and the patient was subsequently planned for palliative chemotherapy. However, he died about 2 weeks after, before the commencement of the palliative chemotherapy. Thank you very much.
Thank you very much, Dr. Idok.
Thank you, sir.
If we can go back to this slide, Dr.
Just back to your slides.
Back to my slide. Yes. I will, because of time, I will not leave the presentation to open our discussion. But if anybody has any audience, maybe we can take one comment before we move on. Let me at this point acknowledge the attendance of Dr. Jimmy Coker, the CEO of Lagoon, who was my colleague at the UK here. He's also a colorectal surgeon. Thank you very much for attending this. This is probably not uncommon, the presentation you heard just now. Do you have any comment on that?
Yes, thank you very much, Banji. The only comment I have is that rather than doing an ileostomy, I would have looked at doing an ileotransverse anastomosis so that at least I can ensure that he has a reasonable quality of life. It looked as if it was going to be one of those cases where you're damned if you do, you're damned if you don't. I didn't notice any comments on the CT scan as to the presence of multiple liver metastases or mental seedlings, because I think there could be a discussion as to whether or not this patient will have benefited from surgery at all. But I know the pressures people are under at home to do something, quote unquote. But the only comment really would be, could we have done an ileotransverse anastomosis here rather than an ileostomy? Thank you.
Can I?
Yeah, thanks. Yeah, Mucho, yes.
Okay, before I do that, there's somebody, Olua, somebody who was raising his hand up just now. I saw him. Okay, I was going to echo what Jimmy.
Hello, sir.
Hello. Okay, do you want to talk?
Yes, sir. Please, can I go on, sir?
Yeah, go on.
Yeah. Just read the comments the last speaker had. I was thinking that he actually nailed it on the bed. Back here, it's a lot of pressure when a patient comes in and is obstructed, and then everybody wants him to do something. And the truth is, when a patient is obstructed, so we need to actually do something. Maybe just being a little bit prejudiced about this particular patient. I think I was at surgery. The whole abdomen was sort of caked. We could hardly mobilize any part of that body.
Okay, I thank you for that comment. I mean, and I think that I'll probably go back to what Mr. Cooker has said.
And
I
the
think
CT scan too had a lot of.
Oh, sorry, go on.
Can you hear me, sir? Yes,
No, sorry, you went off.
Yes, sir. The CT shows that there were multiple nodules all over the peritoneum, everywhere. So the best we could do was to just try and pull out some loop of the bowel and then.
Are you still talking? Hello? Okay, it seems that you've gone quiet. Okay, you're cutting in and out.
Yeah, I'm so sorry, sir. Something was disturbing my call. I'm going to put that up now, sir. Hello. So basically, it would have been. It was actually.
Okay, I think we obviously you are cutting in, and we haven't heard half of what you said, but I think I get the gist. Your CT scan, and that's an important part.
A tug of war.
Okay, Mr. Jagbe, Dr. Jagbe, we'll cut you off because we can't hear you. You keep on cutting in and out, but I've heard a lot of.
I'm sorry about that. It's fine, sir. I think I just made my point.
Okay, that's fine. So I think that two things are important, because I'll just start out with what Mr. Cooker just said, is that your CTs can actually show that this guy had peritoneal nodules and had a very advanced disease. And I think that the question that one has to ask is that in this stage, we don't know how much of the liver is affected. But in this stage, when the patient comes in with bowel obstruction, I don't know whether it's multi-level, with peritoneal seedlings, with liver metastases, the question that I would ask myself is that how long does this patient have? Am I going to kill the patient by operating on him earlier than he would have, or does it need time with his family? And I think that one has to take the family along with that. And I think from what you said, it's possible to have decided right from the word go that an operation would not be in the best interest of the patient. And I think that really is the most important question. I think the important question is, they've got a life-ending disease. Are we going to do anything? My cutoff point is that if you have 3 months of life left, then I would operate if I can. I would close if I get in there and it's full of seedlings. But that's the most important question. I think, thank you for highlighting what you found on CT scan. And I think that's partly what Mr. Coker was alluding to when he said what the decision about to operate on the patient. I think that's why I wanted to see the pictures, but you've told us about that. Should we let, Mr. Oshowo continue?
Yes, thank you very much. Yeah,
Maybe
thanks.
I'll share your screen.
Okay, thanks, Dr. Idoku. That was well, I was going to say a good case, but it was a sad case, but actually highlighted perhaps what my take-home message is on this lecture, that this is a 57-year-old man. Unfortunately, why did he have to present late? Why did he have to present as emergency? This same person, I mean, he came in at stage 4, basically. That's with due respect, anywhere in the world, I don't think there's anything anybody else could have done to save him. But perhaps 6 months earlier, or maybe a year earlier, he could have been cured. That's food for thought. And that is where I really want us to start thinking about prevention, about screening, about colonoscopy, and they will do a lot of audit around this, and maybe public enlightenment. It's kind of very difficult even in a society like ours. I mean, in UK, it's still a problem. People are still presenting late. But if we can avoid this, that will ensure that patients are having good quality of life and improve survival from their cancer. Okay, thanks. Let's move on. The slide I have here again just demonstrated the common sites of cancer. You can see it's more on the left side than on the right side. Left side meaning if you take the sigmoid and the rectum combined together, you're looking at almost 60% of colon or colorectal cancer will be in the rectum and in the sigmoid, and very few cases in the right side. The commonest presentation will be by and large change in bowel habit. Very few patients who come in presenting with iron deficiency anemia. And iron deficiency anemia could actually also signify upper GI problem rather than a sickle cancer problem. But they do need to have what we call top and tail. They have to have a right side of the colon examined as well as the stomach examined. People still come in with emergency and then with abdominal mass, which is unfortunate. Now, the next slide, we won't go too much into that. It's just a comparison of the effectiveness of Q-FIT test in terms of looking at the symptoms. If you put all the symptoms together and you do Q-FIT test, you can actually confidently say that if the Q-FIT test, it comes in as a quantitative result, if it comes in as less than 4, even with symptoms, you can reassure the patient that there's no cancer there. Whereas when the Q-FIT result is quite high, for instance, if you're getting about 200, then it's from the next slide, Brandy, if you for sure, if you're getting a Q-FIT result of greater than 150 or 200, then it's quite alarming. That means the risk of colorectal cancer is quite high. So we do place a lot of emphasis on Q-FIT tests in order to stop everybody from being referred to a colorectal center. Because once they come in with a positive Q-FIT result of greater than 150, They do go for what we call a straight to test colonoscopy without undue delay in the outpatient clinic. They go straight for colonoscopy, which is the gold standard. And you can see from the next slide, colonoscopy is about 95% sensitive. During colonoscopy, you can do a biopsy, you can do a tattoo, you can remove polyp, even early polyp cancer, you can remove them. And if it looks remotely like a cancer, you need to arrange the staging investigation straight away. You need to arrange CT scan for chest, abdomen, and thorax and pelvis. We understand some patients are not able to go through colonoscopy for obvious reasons. If they are too frail, if they are diabetic with their inability to tolerate bowel prep, they alternatively can go for CT colonography. It's not as good as colonoscopy, but it's comparable. You get about 94% sensitivity rate with CT colonography, but you're not able to be specific. Sometimes you have a large stool with poor bowel prep and you cannot tell if it's colon cancer or not. And lastly, we do flexible sigmoidoscopy. If you think the symptoms are mainly red, fresh bleeding, but you have to be careful that the patient does not have a synchronous tumor. It's very rare to rely on flexible sigmoidoscopy only. Now, the next slide, I do not think, just for the sake of people who have not seen endoscopic view of a colon cancer, that's typically what it looks like. Most of the time when you see a cancer in the colon, you know it's a cancer. The polyps are quite difficult. Sometimes you may not be able to tell if a polyp is cancer, but when you have a large lesion like this, it's until proven otherwise, it's a cancer. And the next slide just show there the CT scan of the liver. You can see the multiple hypodense areas showing multiple metastases. So once you've collected all the staging results, which would be biopsy, getting a full histopathology, your pathologist should be able to tell you a few prognostic mutation results like KRAS, NRAS, and those are the things that will actually determine whether they are sensitive to certain types of chemotherapy. Your CT scan must include the chest because we know that chest and liver are the two common areas where there are secondaries. For all rectal cancers, you must include a MRI. It is best to do MRI to stage the rectum rather than CT scan. And occasionally you have to do a PET scan, but they're not necessary in the initial investigation. And all cases are discussed at the lower GI MDT before they are offered definitive treatment. Now, the next slide briefly is there to remind us of the blood supply, which in a way also shows us the resection. When you're going for oncological resection or oncological clearance, you know that the lymphatics also follow the blood supply. So if you're dealing with a patient with a sickle cancer, you are not just going to do a cystectomy. A lot of medical students ask me, why do we have to take out the whole of the right colon? So it is because you're looking at the marginal vessels and the lymphatics also follow all the vascular channels. So you have to do what we call an oncological clearance, which on the next slide, you can see what we mean by oncological clearance. The lymph nodes along the bowel, along the marginal vessels, they are what we call the D1 lymph nodes. It's not enough to remove just those ones. You want to go to the apex. So you want the apical nodes, which is almost the level of the origin from the aorta. If you're dealing with, for instance, you're dealing with a right colon cancer, you want to go to deep down to the apex, the ileocolic and the ileocecal vessels. If you're dealing with the left-sided colon, you want to go to the IMA and take out the apical nodes. Now that's D3, and you put a suture there to let the pathologist know that that's the highest level lymph node. Now, if you can get a D3 clearance, it's what we call a complete mesocolic excision, and that gives you a complete oncological clearance. So these are all kind of some technical details, and they are good. They are important in when you're talking about recurrence. The next slide talks about the just looks at the different staging. We still use the Duke's classification as well as the TNM. Both of them are good. This slide is actually quite good. I think you keep them for reference sake, because if you have a Duke's A, it does not tell you the whole story. A Duke's A can be a T2, whereas it could actually, in theory, still mean that the patient needs treatment. For instance, if you have a T2 tumor in the rectum, which is anterior, you will think that that tumor needs more treatment. Now, somebody's left open.
Yeah, Mr. Dr. Isame.
Okay. So these are all the things that you discuss with the oncologist and the histopathologist at the MDT, so that you look at each specimen, each patient, before you prescribe the treatment for them. Again, I'm not going to go into oncology on this presentation. Yeah. So this is just for us to bear in mind that the Duke staging, the TNM classification are both important, and they should be looked together. Now, the next slide, again, it's really saying to us that early diagnosis is important. Straight to test is important when the patient is symptomatic. They do not have to wait with other patients for a routine appointment. They get the appointment quite quickly. We have what we call a 2-week wait, and they all label as target patients. So they have the treatment quickly, they have the CT scan quickly, with a separate pathway coordinator who monitors all the investigations. So there are several different treatments available. Some can be minimal invasive, some can be radical, open surgery, laparoscopic surgery, robotic surgery. These are all decided at the MDT. Therefore, all the patients go to the MDT to decide what's the best type of treatment for them. And lastly, there you can see what I call the enhanced recovery care, because after the surgery, a patient needs to be nursed properly, and we have specialized nurses who are trained in enhanced recovery. Again, that is a different topic for another day, because enhanced recovery essentially means that you want the patient to get up and go and leave the hospital as quickly as possible and as safe as possible to return to their normal functional stage. The next slide, it's just to remind us the different types of surgery you do. On the next slide, please. Yeah, this one. So these are, just to avoid confusion, people still don't understand the difference between a low anterior resection and a high anterior resection, sigma colectomy, left hemicolectomy. It's really depends on where the cancer is situated. it's easier to say right hemicolectomy because you're taking out the right colon, which means you're taking out the tumor proximal to the midocolic artery. Whereas when you do a left hemicolectomy, you're taking the IMA and then it's usually on the left side. The one that is most confusing really is the high and low anterior resection. Personally, I do what is called a high anterior resection rather than doing a sigmoid colectomy because I think to achieve a better clearance with the high anterior resection than the sigmoid colectomy.
Can we mute our microphones, please? Sam Esele.
Okay, it will be a few more slides and then we can.
Sam Esele, can you mute your microphone, please?
I cannot mute.
Okay, you have muted now.
Excellent, thank you very much. So, understandably, not all the patients will be suitable for resection. If either because the tumor they're presenting as emergency, in which case, if there is time, we can actually put a stent. You can see that wire you're looking at in the colon is a stent. So that stent can be deployed to allow or to relieve the obstruction. And the importance of this is that when you put a stent, the patient can now be staged properly. They can come back for an elective surgery rather than you trying to do an emergency surgery in the middle of the night, probably not by your team or by some emergency surgeon. Whereas with a stent, they can actually come back for elective surgery. They can have the staging investigation, chest, thorax, abdomen, and the pelvis scans, and they can be discussed at the MDT before the definitive surgery. I think that's so much for the colon cancer. It's usually quite straightforward, not as complicated as the rectal cancer. And I'll just say here that colon cancer is mainly adenocarcinoma, and I think 95% are adenocarcinoma. You have a few cases of lymphoma, a few cases of squamous cell carcinoma or transitional cell carcinoma, but by and large, and also neuroendocrine tumor. I shouldn't say neuroendocrine tumor. Some people don't believe they are cancers, but by and large, when you refer to colon cancer, you mean adenocarcinoma. Now, rectal cancer presents a different problem. You can see the patient, the picture shown here is just shown a tumor in the rectum. You cannot tell what sort of cancer it is. By doing your rectal examination, if you're able to get to it, you can test if the patient, if the rectum is, if the tumor is mobile or not. That's all you can tell. MRI is more predictive. It tells you about the surrounding structures because the pelvis is everything is all squashed in the pelvis. So it's very, very likely that a small cancer that you're looking at in the rectum is actually deep-seated and it's already infiltrating the structures. And for instance, in male, it may have breached the mesorectum and then also involving the vagina in female or going to the prostate or prostatic bed. And therefore, when you're doing surgery, it will be very, very difficult to achieve a clearance. So where surgery is still the mainstay of treatment, next slide, please. Surgery is still the mainstay of treatment, but now what we do is to select some of these patients for what we call a neoadjuvant treatment. That means you give them initial radiotherapy with or without chemotherapy for two reasons. One, to downstage the tumor, and then two, to actually shrink the tumor. When you shrink the tumor, a tumor that didn't have a plane previously, you find out that you are able to do a total mesorectal excision. And while this is being done, it's actually patients who come back with about 25% of the patients showing complete response to the neoadjuvant treatment. That means you've done your neoadjuvant treatment, and about a quarter of them don't have any tumor left. There's no residual tumor. When you do your MRI or even a biopsy, there's nothing left there. So it's still quite difficult to know what to do with them. If they are old and frail and elderly, that's probably easy. You just leave them alone. You don't need to do any radical surgery. But if they are young, it's still, I think people still say that you should go ahead and do what you plan to do before the neoadjuvant treatment. That means you go for the radical treatment surgery. There are other forms of modalities. If you have a polyp cancer or a superficial cancer in the rectum, they can be treated effectively by what we call TEMS. TEMS is transanal microsurgery. It's almost similar to endoscopic resection. You insert it through the anal canal, and then you resect the tumor, and then you close the mucosa. It's quite good in patients with T1 tumor or in elderly people who are frail and not able to go through radical surgery. The advantage of TEMS is that they don't have a radical procedure, no laparotomy, and the recovery is quite quick. The disadvantage is that there is sometimes lymph node involvement, even in a T1 tumor. There's a risk of about 5 to 10% lymph node involvement. So those patients really need to be monitored. You need to continue to monitor them by regular scanning. And it may be that over the next 2 or 3 years, they will still end up having the conventional resection for the tumor. Now, the next slide gives an overview of what to do. Generally speaking, if a tumor is in the upper and middle rectum, they do not necessarily need to have what we call AP resection. You can do an anterior resection. It could be a low anterior resection, and then you're able to preserve the sphincters. You may be able to get away without a defunctioning stoma, but if you are not entirely happy, it's not uncommon to give them a defunctioning or covering stoma. Now, for the lower rectum, lower rectum is within 5 centimeters of inner verge. The first consideration really is AP resection, just take out the sphincter and everything. But where the expertise is available and where they've been for neoadjuvant treatment, it is possible to do sphincter preserving surgery, even for low anterior, for low lying rectal tumor. It's safer or quicker to do an AP resection, but AP resection will be a permanent colostomy, and you have 1 or 2 patients who will definitely say no to that, in which case they can be considered for sphincter sparing procedures. Now, there are other cases of rectal tumor whereby it's already T4. The pelvic organs are involved. The sacral bone, the coccyx is involved, but there is no liver or lung secondaries. These sort of patients can be treated with what we call pelvic exenteration. So the entire rectum, the prostate, even the bone, all taken out, and that's possible. And then they end up with their end colostomy. So you can see the different modalities of treatment. The next slide, please. So what will make you think of doing a TAMS or local resection in rectal cancer is if there are T1 tumor, which has been staged correctly. It's all limited to the submucosa. There's no radiological evidence of metastasis, and the tumor is small, less than 3 centimeters. Now, you can feel the tumor if it's mobile, not hard, not fixed, not indurated, and it's definitely not involving the whole circumference of the bowel lumen. Then you can do a local resection of the tumor, even at any age, and just follow up the patient. There is a surveillance program whereby you follow them properly in order to identify recurrence quickly. Now, for all the other cases, next slide, please. For all the other cases, it's essential to do, in addition to the CT, chest, abdomen, and pelvis, it's essential to do the MRI for proper staging. You're looking at trying to identify patients who will go for neoadjuvant treatment and the patient who you can offer surgery in the first instance. So if it's a T1, T2 tumor and the nodes are negative, you can offer surgery directly, anterior resection. Whereas if radiologically it's T3 or T4, or if it's an anterior tumor and it's kind of aborting at the level of the mesorectum and involving the fascia, then you need to recommend neoadjuvant treatment. Now, neoadjuvant treatment, usually radiotherapy, is for a period of about 6 weeks, and you allow another period of about 6 weeks to look for the effect of the radiotherapy before you do your surgery for them. Next slide, please. So as mentioned earlier, after the neoadjuvant radiotherapy, about 15-20% of them will actually have a complete response, in which case there is nothing else found, no tumor left behind on your MRI. What do you do with them? It's still up for discussion at the MDT. You can wash and wait, or you can advise straight to surgery. Now, if a patient is young, fit, I think the tendency is to go for surgical resection unless the patient themselves do not want this. If a patient has comorbidity and elderly, it's usually the MDT will always say, no, don't go for any further surgery, leave them alone. You just watch and wait, and you can continue to monitor them regularly. The advantage of watch and wait is that you avoid major surgery, you avoid stoma, you avoid all the complications of surgery, and it's considered to be safe in a few papers that have followed up their cases for about 3 years. It's considered to be as good as having a resection. I think in the years to come, it will be more popular to have radiotherapy alone and then watch and wait. On the next slide, I'll quickly just mention that after all you've done in colon cancer, rectal cancer, even with the best oncological clearance, there is still about 10% of recurrence. And the recurrence can be at the anastomotic level, it can be in the mesenteric lymph node, it can be in the peritoneum, which are all local. Or you can have a recurrence in the liver or in the lung. it's very rare to have a colon cancer in the bone or in the brain. So usually it will be a local recurrence or in the liver or in the lungs. It's still not the end of the world because all our patients are followed up for 5 years after their initial surgery. So we have what we call a remote follow-up. So everybody gets a CEA. By the way, CEA is not a diagnostic investigation. It's the use of CEA is in the follow-up. If you have a rising level of CEA on follow-up, you're more worried. So CEA and a regular CT scan, abdomen, chest, and a thorax and a pelvis. And they also have 2 yearly colonoscopy. So we have what we call a remote follow-up. There is a CNS, a nurse who is in charge of that. And if at any point there's a recurrence, they are brought back to the MDT and discussed further. Now, the next slide, please. Next slide shows what is available when a patient has a recurrence. Now, I'm just going to mention this HIPEC because it's a new way of treating our patients with peritoneal deposits. In the past, there is really nothing to do for them other than their palliative chemotherapy. But now, if a patient has peritoneal nodules, they can go for aggressive intraperitoneal chemotherapy, and coupled with exenteration or excision of whatever nodule that is present in the peritoneum. So this is really an aggressive treatment. Sometimes it can go on for about 4 or 5 hours on the table. It's supposed to improve the quality of our patient's life and also the survival. So instead of getting a 5-year survival, 5% 5-year survival, they actually can go on for about 10, even longer years. Now, the other forms of treatment for recurrence would be liver resection or pneumonectomy or lung resection. So all these things are available in the MDT. So when a patient comes in with recurrence, it is bad, but we also try and treat them aggressively. The next slide, I think we briefly mentioned that in the early presentation, and that's use of colonic stent. It's becoming very popular. Stent is metal. I showed the picture in the early slide. It's used as a bridge to surgery. If a patient comes in with large bowel obstruction and it's down to colon cancer, endoscopically, you can place a stent which is self-expanding and it allows the obstruction to be relieved. Now, the advantage of this is that you can now plan the operation at an elective time, whereby the bowel is now prepared. The risk of anastomotic breakdown or risk of just doing a colostomy is considerably lower. So you have more confidence to treat the patient the way you treat the same type of patient who is not obstructed. Now, the disadvantage is that during the placement of the stent, you can perforate the tumor. And you can leave if you have not perforated the stent can migrate in the next few days after you've placed it. It can migrate and the patient still comes back with their obstructed. So it's still in the early stage. It's very useful if it's placed properly and it works well in those patients. Oh yes, the next slide, for sure, that shows a well-placed colonic stent. You can see there is lumen. The lumen is restored. This patient can now go back to their normal life, have a staging investigation, go to the MDT, and then have an elective surgery or fairly urgent surgery. The last slide, really, I think it's just to say that chemotherapy is not my remit in this presentation, but just for all surgeons must know why they're giving chemo. It's used as adjuvant, in which case you are using it in a patient who has undergone a curative resection. You can use it neoadjuvant. That means you're giving the chemotherapy before surgery, as I've said earlier, in rectal cancer, we use it a lot. Or palliative. Palliative means, well, it means palliative. So it's a patient who you're not expecting cure, but you are looking at improving their quality of life. You're looking at improving their symptoms, in which case you offer them palliative chemotherapy. And I think for surgeons, you need to know the various forms of chemotherapy that is available. Usually, there's this first line, which is the oxaliplatin and the 5-fluorouracil and irinotecan. They use them in combination, and the 4-FOX, 440, Capox, so different ones. Or the second line would be the monoclonal antibodies, and the cetuximides, etc. And the third one, the immunotherapy. So there are different combinations that are used. In my practice, oncology treatment is not undertaken by surgeons. So although we sit in the MDT together, but they go straight to the oncology clinic for this to be done. I think we're coming to the end of the presentation, but I'm just going to show you the last slide, which is what summarize the treatment, the surgical treatment available for colon cancer. So if you start from the diagnostic endoscopy, that's now considered to be part of cancer treatment, cancer surgery. And a lot of colorectal surgeons do it. It's not left for the gastroenterologist alone. So if the level of invasive tumor, the level of invasiveness is low, you're looking at T1 tumor, then endoscopy alone is good. You can do endoscopy polypectomy, endoscopy mucosal resection, and successfully you can do them. But if the level of invasiveness is quite high, now you can still consider TAMIS. TAMIS is TAMS. It's a transinal microsurgery, or now you can go into the other part of surgery, which is now becoming popular. That's the robotic surgery. Now, the advantage of robotic surgery is that it eliminates completely the human factor. Most importantly, in pelvic surgery, where you actually need accuracy there when you are dissecting the TME plane. Now, laparoscopic surgery is considered to be standard, except for patients who are not able to undergo it. Patients with cardiopulmonary problems in particular, because when you give them pneumoperitoneum, you cause trouble. And also patients with previous numerous laparotomy. Now, open surgery is still the standard, is still the go-to surgery, especially when you're dealing with patients with T4, emergency, extensive tumor, metastasis, exenteration. Open surgery is still what you go for. So thank you very much. That brings me to the end of the presentation. And if there's still time, we can take some questions. Yeah.
Okay, thank you, Mr. Oshowo, for the wonderful presentation. If you're not talking, can we mute your microphone, please? There's some questions that's on the chat. Before we go into the questions, can I remind everybody, and now that we're finished, can you please log on to this website and start filling in your feedback forms, please? Can we all fill the feedback forms before we finish this session? Okay, I'll send up the address to remind you what the address of the site is if you don't remember. I think there was a question before, which probably so what was the stage? I'm not quite sure. Was referring to the presentation. It's a stage 4 cancer, and he said, "Could screening have saved his life?" I think you've already answered that question. Yes, screening will have saved his life. So we'll move away from that. The next question is by this is Jimmy Coker. Jimmy Coker, Jimmy explaining what MDT is to everybody. Okay, I think thank you very much. Thank you very much, Jimmy, for that actually. And also apparently tumor boards may be more familiar with people, because I was going to actually ask the question that do you have MDTs, but obviously it seems to be tumor boards. Do you before I go, do you have tumor boards or MDTs for colon cancers and UCH? Funny.
For colon cancer, no, we don't, sir.
So okay, so the decision about the individual patient rests with the consultants.
Yes, it does. Usually with the surgeon.
I see. Okay, and then the other question is.
Yeah, but hang on. But I think they do have tumor boards. Don't you have any tumor boards at all?
We have.
I think they may have for breast.
We do not really. We actually have for thyroid, not for the breast one. Is really not functioning properly too. It's just what I to the thyroid, but the breast, no, not really. The colon, definitely no.
Okay, all right. Thank you.
And then the other question that the question I was asking Mr. Oshowo briefly referred to, who does your chemotherapy? Is that still surgeons, or do you not have oncologists that do that?
It's a mixture of both. For the breast, it's usually the surgeons. The colon surgeons most times, but the radio-oncologists too give chemotherapy sometimes. We don't have pure oncologists. No, we don't.
You don't have
the surgeons the surgeons or radio-oncologists that do the chemo.
Okay, thank you for those answers for me. Mr. Yusuf Oyedokun, who did the presentation, Ayo, has asked if you could briefly talk about anterior sections as regards to high, low, and ultra low. You've referred to all of that. Okay, can I just briefly modify that? If you have a distal sigmoid or high anterior section, would you always take the IMA, high IMA or low after the left colic? Go
on. To me?
Yes.
Yeah. Yeah. Rectal sigmoid tumor are usually considered to be rectum anyway. So if you have a distal sigmoid, it's done as a proper high anterior resection, you take the IMA. Whereas if it's sigmoid, then you do not necessarily have to take the IMA. You can take the anterior branch of the IMA along with the tumor, almost similar to doing what we call a left hemicolectomy, and avoid the rectal branch of the IMA.
Okay, so do you take down your splenic flexure for all cases of high anterior section?
No.
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 Okay, let me just get that nomenclature right. That's fine. Let me just get that nomenclature. When you say you take high, when I refer to high IMA, is taking your IMA before or after the left colic?
Always after the left colic.
That's before the left colic. You're taking the left colic, you're taking the IMA close to the aorta.
Close to the aorta, that means you're taking the apical. Yeah, you're taking it high. That's high.
Yeah, that's high, yes.
Yeah, that's right. That's correct. That's for all anterior sections. You take it high.
You take it high. Okay, that's fine.
Yeah, for all anterior sections. Yeah.
Okay, so the question was, I don't know whether there's anything more to add to that. You said that's a question from Oyedokun, Dr. Oyedokun, with regards to high, low, and ultra low anterior section. Do you have anything to add to what you said?
I think where it will be confusing really to a lot of people is what we call ultra low anterior section. Ultra low is when you're dealing with a low rectal tumor, usually within 5 centimeters of the rectum, you can get away doing a low anterior resection. Now, when they are within 2-3 centimeters of the sphincters, it's dangerous. Well, not dangerous. Functionally, it's impossible for a patient to cope with that when you take the sphincter along with the operation. Now, if you've given a neoadjuvant treatment, you will still be able to achieve at least 1 centimeter distal clearance, which is considered to be adequate enough. If you can get 1 centimeter distal clearance away from the sphincters, then you can do what's called ultra low anterior resection. That means ultra low means you're actually almost on the sphincters, and then you do your anastomosis. In most cases, you actually find it difficult to use staplers. In fact, almost impossible to do staplers. You now have to come down to the bottom and do a hand coloanal type anastomosis, which is usually what you do for a patient who is adamant they do not want to have AP resection. Some patients will rather die than have a permanent colostomy. Yet in those patients, you still want to achieve oncological clearance. So you have to be able to do ultra low anterior resection in order to achieve that.
Okay. Do you have any other questions? Sorry, I've just opened up the feedback. It wasn't open before, but please, can you put your feedback? You all know that it's important to all of us. Any other questions? Let me just see what else we have on the chat. Who has? I think somebody was just saying the question has been addressed. Okay. Any other questions from everybody? Okay, Jimmy, what did residents are thinking? Jimmy, is there anything to add from your point of view about how?
Thank you.
Sorry, Jimmy, hang on a moment. I've got Fumi on the raising her hand. Fumi.
Yeah.
Oh, actually, I'll look at the feedback. I see the feedback on the site.
You go on the feedback on the side. You go down to the colorectal part. So you keep on scrolling down. There's a feedback. It's above the presentation that you have from Mr. Yedukun.
Okay, let me check again. I didn't see it. I'll do that. I'll check again. I'll log out and log in again.
Okay. Yes, it's above the feedback from Mr. Yedukun. I'll put it down. I'll shift it down to be to the last.
Yes. So thank you very much, Funsho. And a number of comments, really, more than questions. The first is that because we don't have a structured screening program in Nigeria, what I have tend to do, and I have advised people to do, is opportunistic screening, particularly for people with symptoms. So if you're coming and you complain of rectal bleeding, I would tend to use the opportunity to provide a colonoscopy if necessary. Another point is that because, as you know, the cancers in Nigeria present almost 10 years earlier than those that are seen in the West. So the cutoff age then drops from around 50 really to around 35, 40. So that's the second comment. What I have found, MDT meetings, we really had a lot of problems initially trying to do them at Lagoon, simply because a lot of people just felt that they didn't have time. But the beauty of the pandemic is that it has shown that, if really one wants to create time, one can create it. And we've been able to then have virtual cancer MDTs now, which involves 3 surgeons. There's a liver surgeon, 2 colorectal surgeons. We have the 2 oncologists. We have 2 radiologists, and we have 1 gastroenterologist. So all in all, it's been working well, but I know that it's a huge challenge at times to get this going. So it doesn't surprise, but I think that certainly I know that in Luth, they do have the breast tumor board. I don't know about colorectal, but like Mr. Oshowo had said, they really are very important. And I think it's something that you should encourage, if it's possible, encourage your bosses to key into. Medicine, the specialties are so highly focused and specialized now that no one specialty knows everything about others, which is the reason why I would encourage that. And I have learned quite a lot, particularly, all the time I was in the UK, I really didn't pay any attention to chemotherapy. But here, one needs to do that because one may end up having to supervise some of these patients who require chemotherapy. I still don't prescribe them. I would normally refer them to the oncologist, but there are times when one needs to supervise them. So those are the things that I would say at the moment. We are trying very hard to continue to encourage people to adopt laparoscopic or minimal access surgery, but it remains a challenge for several reasons. Thank you very much, for sure.
Okay, sorry, Jimmy, you can't get away that easily. Since you obviously worked in both areas, England and in Nigeria, what do you think are the barriers to introducing widespread MDTs or tumor boards, which obviously I'm totally quite surprised. I found out today that they don't have, I thought they did, tumor boards in Nigeria. And also, do you think with the cost of laparoscopic surgery, and it does have some cost, that can be a widespread practice in Nigeria? And the third part I'll add to that, obviously, in the book on cancer in sub-Saharan Africa that we did, the gastrointestinal chapter we have, one of the things we found out was that APR is vastly more common, and the percentage of people who have APR is infinitely higher down across there than it is for low anterior resection. And I'm assuming it's probably because of stapling and all of that. What do you have? What do you say?
Well, thank you. Two things. The first thing is that the reasons why tumor boards have not been adopted, it's really simply because of the mindset and the attitude of the senior doctors, who often feel that they probably know a lot and feel that very few people can teach them things. A lot of them have also not grown up collaborating, and it's not just with MDT meetings. I mean, we had East Midlands Surgical Society when I was in England. We had the Northwest Surgical Society when I was a trainee, and all of those were extremely useful. When I came to Lagos in 2010, I tried to start the Lagos Surgical Society. Not even MDT now, just even surgeons in the city. There are 2 teaching hospitals. Let us bring difficult cases. Let us discuss amongst ourselves. Let us support ourselves. I mean, there's nothing as devastating as having an anastomotic leak or having, difficult surgical problems. And if you have people to discuss with who think like you, then you may get benefit. But really, it was virtually impossible to do that. Then Tunde Ladude came to Lagos too. He rang me to say, JC, I see there is no Lagos Surgical Society. I said, if you like, you can try, because I hosted the first 3 meetings and then nobody, and I felt that it then became a lagoon meeting, but it's not, it shouldn't be a lagoon meeting. There are 2 teaching hospitals in Lagos, but all sorts of things happen. So that spirit of collaboration still needs to be fostered amongst the senior doctors. Now, I think that's beyond the remit of this meeting. The second one is about the high incidence of AP resection.
Yeah.
Yes, you're right about staplers. And I don't know whether Ayo remembers. Ayo and I think we were sitting in Luth. This was probably 2006. We went to do a basic surgical skills course. And we were then in theater, and they were about to start an AP resection. And they had the barium enema of the patient on the screen. And the tumor was at the rectosigmoid junction.
Sorry, okay.
And you know, we looked at each other and we were thinking, who is going to talk first? You know, because we were aghast. I summoned enough courage to say, hey guys, this thing, you can drive a bus, a trailer can do a U-turn below this cancer. So you should be able to do a primary anastomosis here. And that was what then drove me to partner with industry, to spend a lot of time teaching on stapler. I don't know whether you know, I spent about 5 or 6 years training at the different teaching hospitals. And I also actually did it in I think the 60th anniversary of UCH.
Okay.
We came, Ayo and I think Ayo was with us too then, when we went on to do the colorectal stapling anastomosis workshop, and we did the basic surgical skills workshop there. So thinking
Correct.
about sort of 15 years on, there is a higher adoption, but it is still nowhere near enough. Part of it, of course, relates to cost. And honestly, and I know it's difficult for the two of you to understand this, but cost plays a significant factor in the clinical outcomes of a lot of patients in Nigeria. It is sad, but it is true. Because you know, you will have to be given a shopping list. A lot of these staplers are disposable, so they are an additional cost. So, for example, I was quite excited when Auto Suture, which then became Covidian, which is now Medtronic, came to Nigeria with the reusable GIA staplers. They have helped, but we've not really been able to identify maybe the Russian guns, we can revive them. But you know, the reusable circular staplers are not available. They are disposables. So they add a significant cost to the care of the patients, because care in 70% of the cases are still out of pocket. So really, that's I think my overview on the topics.
Okay, Jimmy, that's absolutely well dealt with, and thank you very much. And particularly from your personal experience at Luth, I think that explains quite an awful lot as well. Aya, you were going to say something.
Yeah, I'm just trying to remember how time has gone by quickly, Jimmy. I remember then we went to UCH, and one of the patients was actually one of our ex-lecturer professor.
Yes.
And then we were able to do the anterior resection and then with the staple, and it was quite pleasing. Yeah, that was how I was just going to say. Yeah, I remember that quite clearly. The only other thing I remember about that, I hope that doesn't happen again, is how you were sabotaged at the beginning when somebody decided
the power
not to
problem,
provide
the power problem. Yes, the generator problem. We had not gone to appreciate the generator people, so we didn't have light to operate for like 3 hours or so. But there you go. Ion, you have to adapt to such things now. I have, you know.
Okay. Thank you very much for both. Any questions from the floor before we bring this to an end? It's all about you. Nobody's talking. Nobody's asking questions. Okay. Any hands raised up? No. Ayo, anything else that you want to add?
Yeah. Just finally, from my part, I think it comes down to us doing this program of audits. I've now come to the conclusion that actually we can do a lot of audit based on this topic. There may be data already which I wasn't able to get into, but actually we can always renew them. Even what's been collected in the past. It's quite good to learn from Jimmy that the cancer rate in Nigeria is 10 years younger than or earlier than in the Western world. And I think that is an audit point for somebody. You know, there's so much that we can do to that will not involve too much effort and time and even money. So let's encourage ourselves to do that. I'm happy to supervise.
Thank you very much, Ayo, for that offer. I think that obviously we've got a group of 7 people I think you get the emails I sent out, which we're starting one. So I think we want to do the first one, see how we go with that. And we've had the wonderful support of the head of surgery. His name just escapes me very quickly now, who's emailed his support. And I had a Zoom discussion with him the other week. And he said he was very happy, and he also sees the beauty of having audits, and he actually agrees that audit is an important part. And I've got I think Dr. Shonaye has sent me a pro forma for the first audit, which is on WHO checklist, which we're going to do. And I want to see how that goes. Then we can start expanding that and see how everybody does. Before we shut down, I need you guys to go and do the feedback. I've only got 10 people so far. So you have 2 minutes, 3 minutes while you're still online to do it, or you can do it afterwards. But please, it's an important part for all of us, and it's an important audit too. I think a lot of people have learned from from the previous one you filled about what we need to do to make this better. And I think those things are important so that we know how this is going. So please, can you get on the site? Can you do the feedback? And one final thing, I did the rota for everybody about when they're going to talk, but I did mine as well, which I'm meant to be the next person, and I will be the next person. But unfortunately, I didn't realize I was on call that day. So it's going to be a week later. I cannot do it on the day because I'm first on call. So I might be operating. So it's not going to be on the date. I'll send email to everybody so you can get it. It will be a week later, and it's going to be on trauma. Okay, thank you very much, Mr. Oshowo, for your wonderful presentation. Thank you very much, Jimmy Coker, for having you on and for your perspective on what's going on. Okay.
Always a pleasure, Funsho. Always a pleasure.
Thank you very much, Jimmy. Yeah. And everybody, I'm hoping that all of you, we've now gone through this a lot, all of you will do a feedback. Thank you very much. See you in about 5 weeks' time. And the research group will meet sooner than that.
Okay.
Thank you.
Bye. Thank you, sir.
You're welcome. Thank you, Fumi.
Thank you.
Yeah,
please. You can make the slides available to everyone.
Yes, I'll make it. I've already I'll load it and make it available to all of them. So both slides. The second one, you didn't get onto that. Should I make
yeah, that can be available as well. That's meant to be cases that they can practice on.
Okay, so I'll make both available on the side, and I'll send them email to let them know. I'll make it available as soon as we finish this.
Okay.
Okay. Oshegoni, big caller busy, sha. Oh, you've muted yourself.
Oh no, I'll say it was just a cover. One of my colleagues wanted a cover. I don't know for what, but anyway, it wasn't too bad. Yeah.
Yeah, when I put mine for the next one, I didn't realize I was on call that day, and I've tried to change it, but that's not going to work. But I'll do it a week later. Oshegoni, have a nice, wonderful weekend.
Yes, yeah. Enjoy.
Bye-bye. Thank you. Bye.
Thank you. Thanks, Jimmy. Yeah.